Western civilization. How much do you know? My name is Russell Miles and this is the 22nd episode of our Western Civilization series. In the previous episode we looked at the emergence of HIV/AIDS. In this episode we'll continue the story with the pursuit of a solution, social responses and the beginning of international cooperation. In the last episode, we left off that 1/5 of AIDS cases in Europe were of people originally from sub-Saharan Africa. This had researchers looking towards Africa for an understanding about AIDS. As it was, there had been a newly emerging disease noted in Tanzania, initially referred to as Julian's disease after a cotton cough with that name embossed all over in deep blue background. In early 1983, a travelling salesman had sold this cloth at a village of Mukanya in Tanzania near the Ugandan border and not far from Rwanda. The salesman reportedly had sex with local women who later became ill, not able to keep down food, diarrhoea. Within a year, the disease had spread to neighbouring villages. Patients started presenting at a hospital in the town of Bukoba. Treatment failed to arrest the disease, with patients wasting away. Another symptom was genital ulcers, which normally did not cause death. Inquiries of patients indicated the unusual disease was sexually transmitted. Blood samples were taken to the Mahambali Medical School in the capital Dar es Salaam. Dr. Fred Solomon, the university's chief microbiologist, recalled reading of something similar to Julian's disease in America. The only difference was the American report referred to homosexuals, IV drug users and haemophiliacs. The report also said there was no known treatment. Tanzanian public health officials disputed that the new disease was AIDS. It might be diabetes. But the number of patients in Tanzania continued to escalate. It would not be till 1985 that blood samples were sent to the CDC in the United States which confirmed they contained HIV. The CDC sent an investigator who observed the patients were rapidly wasting away due to a lack of advanced medical care. A common pattern in the Tanzanian cases was that most of the men had been soldiers in the Tanzanian-Ugandan border war a few years before, or travellers who regularly crossed the border. The women had been barmaids and prostitutes, and some had travelled to Uganda, but not all. IV drug use and blood transfusion had emerged as another factor. In early 1983, the former Belgian colony of Zaire had been identified as a significant origin of European patients. In the capital of Kinshasa, a couple of international researchers, with the help of local public health officials, quickly confirmed the number of AIDS cases, 38. The cases were equally men and women, again quite different from the American and European situation. A quarter of the patients died within a few weeks. The patients tend to be from outside the capital of Kinshasa, with no evidence of IV drug use or homosexuality. This study was not published until mid-1984, as it had deviated from earlier findings. Further inquiries in Central Africa identified various cases which may have been AIDS. In 1984 in Lusaka, Zambia, out of 20 blood tests taken for other purposes in the previous year and suspected of being AIDS, HIV was found in 18. There were other cases found in Rwanda and the Central African Republic. In 1985, the first international conference about AIDS was held in Atlanta, with 2,000 scientists from over 30 countries. The CDC arranged for 3 reputable immunologists from Africa to attend: Dr. Kapita Bilia Manu, Dr. Zilia Ziliambi, and Dr. Pango Kazia Elzia, all with extensive experience in Zaire. At the conference, various presentations were made about studies regarding the situation in Central Africa. This included a review of blood samples taken in Kinshasa, Zaire in the 1970s that indicated that 1 in 220 people had antibodies to HIV. Another study said 65% of children in Uganda were infected. There was also reports that 80% of people in northern Kenya had the AIDS virus. These reports were astounding and, if true, would show that AIDS had long been epidemic in Central Africa. But they were erroneous. This is aside from the appalling practice of having published reports without informing, let alone consulting local stakeholders, something never done under ethical guidelines in Western countries. Worse, the samples were cross-infected due to failure to allow for malaria causing a watery fluid that remained on the slides. While the African countries had emerging AIDS epidemics, it was nothing like the study suggested. Subsequent studies using more reliable tests showed that the population incidence in Kinshasa was 10%. By the end of 1985, every region in the world had reported at least one case of AIDS, with 2,303 cases in total. The World Health Organization was to maintain the fiction but diplomatic wise position that AIDS arose simultaneously in 3 separate continents for some years. This fiction would be closer to explaining AIDS than much else. HIV had been classified into 2 types, HIV-1 and HIV-2. It was further divided into a range of groups and subtypes. For HIV-1, there are groups M, N, O, and P, referring to regions, with M the dominant form in Europe, Americas, Japan, Thailand, and Australia. The subtypes are A, B, C, D, F, G, H, J, K, and CRF. For example, A is common in Eastern Africa, B is dominant form in Europe and the Americas, Japan, and Australia, with CRF a recombination of several subtypes. With HIV/AIDS epidemic in North America, researchers sought to trace infected persons back to where they became infected. This was complex as AIDS presented such a wide range of symptoms with long incubation periods. However, HIV is extremely difficult to transmit and only by blood. This meant sexually transmitted, IV drug and blood transfusion, thus narrowing options. In California, one group of researchers traced infections back to a man who had sex with other men in 1978. This man's case was coded with the letter O for outside California. It would be misread as 0, inferring he was the first case. While an early case, he was not the first by a long way. One case, a boy aged 15, was determined to have died of AIDS in 1968 in St. Louis. This assessment was based on records of his medical condition. In the search for other cases that may match AIDS symptoms, there was a blatant recognition that homeless women in New York streets had been early victims, often IV drug users. Their various chronic health problems, described as junkie flu, and similar to symptoms for AIDS. The women being disconnected from health services had hampered identifying the epidemic. In 1985, Dr. David Sencer, New York City's health commissioner, proposed the distribution of clean needles to prevent the spread of AIDS. However, civic officials were concerned about law enforcement needs and mixed public health messages. In 1987, a New York Department of Health report stated that cases increasingly came from intravenous drug users in minority communities, with a big problem amongst women in New York. The problem of AIDS was denied in many parts of the world due to stigma of STIs, hatred of homosexuals, toxic masculinity, and religious and ideological teachings. For example, in 1988, Joseph Ratzinger, the then prefect of the Sacred Congregation of the Doctrine of the Faith, said that the use of condoms to prevent STIs would result in at least the facilitation of evil, not merely its toleration. Chinese officials initially view AIDS as primarily a consequence of Western lifestyles. In the former Soviet Union, officials denied that any HIV infections were occurring within its territory. The records of patients diagnosed with HIV in 1984 were expunged. At present, Russia is believed to have one of the fastest growing HIV/AIDS epidemics in the world. In 1991, the French weekly magazine La Vie du Jeudi published an article alleging that the Centre National de Transfusion Sanguine had knowingly distributed blood products contaminated with HIV in 1984 and 1985. In 1999, the former Health Minister Edmund Herven was found guilty of manslaughter, although no sentence issued, and he continued to serve in politics. South Africa has one of the highest number of people affected with HIV, with a prevalence rate for adults of 19%. Former South African President Thabo Mbeki had publicly denied links between HIV and AIDS and banned the use of retroviral drugs in public hospitals, leading to premature deaths of between 330,000 and 365,000. In 2003, the government approved a plan to make antiretroviral treatment available after the cabinet overruled the president. In 1985, Brazil had returned to democratic rule from a military junta when the initial AIDS cases were reported. The Brazilian response to the AIDS epidemic is considered a model, with condoms and needle exchange programs, universal provision of retroviral drugs, progressive social policies, and collaboration with non-government organisations, prostitutes, homosexual advocate groups, and in 2003 same-sex marriage law reform. The incidence of HIV in Brazil is considered stable, but rates of new infections vary significantly across the country. Our next podcast will conclude the story of HIV/AIDS, exploring its origins, the false leads, and the development of a global response. If you like this channel, please subscribe and tick like. Let me know what you think in the comments below. I can be contacted at email russmills@iprimus.com.au. Thanks for listening.